Welcome back to Open Med School. The last session we have discussed about the history taking in heart failure. Today I will be discussing systemic examination. What are the points to be looked for when you are suspecting heart failure? So the objectives are: perform a systematic examination in heart failure, identify signs of severity, correlate the findings clinically, and prepare for bedside examinations. Vital signs are vital. So any patient with heart failure, check the pulse. What's the relevance of pulse? The support for heart failure is the sympathetic nervous system. The pulse rate increases. So unless a patient is on a beta blocker, a patient with heart failure usually will have, or heart blocker, will have tachycardia. That is one point, keep in mind. Blood pressure should be examined in both arms and check the respiratory rate. Respiratory rate is something which is often not examined properly or not recorded. So this is a very important physical finding that you should look for. Respiratory rate is the most neglected vital sign. Of course, you have to take the temperature. The fever may be due to infected endocarditis, some infection precipitating heart failure, or patient with myocardial infarction, pulmonary embolism, etc. can also present with the fever. So vital signs are vital. Now going to the general examination, examine the patient for pallor. So pallor can occur in infected endocarditis, or pallor itself can present with heart failure. So looking for anemia is very important. And if you are getting anemia, you have to identify what is the exact cause of anemia. Look for other features which give a clue to the etiology of anemia. Second, cyanosis. It may be due to congenital cyanotic heart disease, Eisenmenger syndrome, or heart failure presenting with cyanosis. So identify whether it's a peripheral, central, or mixed. Looking for pedal edema. It's actually not pedal edema, it is a dependent edema that you should look for. A bedridden patient, the dependent part is sacral region. So press over the sacrum for 1 minute and see whether there is a pitting is there. So looking for edema. And again, edema may be unilateral. So the suspect in such cases, pulmonary embolism, because it may be due to DVT. Cachexia. Extreme cachexia can occur, that is called cardiac cachexia. That is, various mechanisms are there, maybe due to malnutrition, maybe due to the heart failure itself. So for drugs like digoxin. Remember, heart failure is a systemic disease. So that is a point to be remembered. Heart failure is a systemic disease. So once you examine the pulse, blood pressure, temperature, respiratory rate, and SpO2. These are the major vital signs. Then you go for a proper general examination. So once you are doing that, in the general examination, look for signs of infected endocarditis, or stigmata of infected endocarditis should be looked for in all cases of heart failure, because one of the cause for heart failure is endocarditis. Again, think about pulmonary embolism. And again, the last time we have discussed some of the precipitating factors like infections, Correlate syndrome, arrhythmias, but there are other precipitating factors. So anemia is one thing, pregnancy, hyperthyroidism. So look for any other clues that can be identified in the general examination. Now we go to the one of the next thing. So usually we examine cardiovascular system, history taking, vital signs, pulse, blood pressure, then GVP. Then go for the pre-codal examination, then go for the other systemic examination. And I have discussed the examination GVP in detail in one of the previous sessions. Please go for that. Here the point to be remembered is that the best position for examining GVP is the position with GVP is best seen. Suppose the sitting position JVP is visible, there is no need to make the patient 45 degrees. If in the sitting position JVP is not visible, you make the patient 45 degrees and then look for the JVP and learn the correct method of examination using two scales. So identify the upper level, measure the vertical height. The best clinical index of right heart pressure is clinical examination is the JVP. So JVP is important because when the right heart failure occurs, whether the right ventricle or right atrium, the right atrial pressure increases and then the JVP gets elevated. So examination of JVP is very important. Read about the details of the JVP. Then along with the, if you are not examined the other peripheral pulses, examine all peripheral pulses. So radial, carotid, femoral, look for all the features of pulse, rate, rhythm, volume, character, radial delay, radiofemoral delay. Palpate all peripheral pulses, look for the thickening of the pulse. In heart failure, one of the things is the pulses alternance. What is pulses alternate? The alternate pulses are large and small. So pulses alternance is a regular pulse. Alternating pulses are large and small. So it's a regular pulse. Should not confuse with the pulses by Gemini, where two pulses occurring, one is large and one is small. So this is a irregular pulse. This is a regular pulse. So examine the pulse properly, and by examining you may be able to identify various types of etiologies of heart failure. For example, in aortic stenosis you may get a pulsus parvus et tardus. In aortic regurgitation you may get a high volume collapsing pulse. So the character, all these are important. Due to lack of time, we will not be discussing that. Okay. Now go to the examination of the cardiovascular system properly. So in the CVS, most important thing in the pre-call examination is one is apex beat. Second is position of trachea. So trachea and apex shifted, it means the mediastinum has shifted. Trachea is central, apex is shifted, that means it is a cardiomegaly. So look at the apex beat, identify whether the apex is shifted. If it is shifted, and identify the character, whether it is normal, whether it is a forceful, whether it is sustained or heaving type of apex. Then look for parasternal heave, right parasternal heave. Sorry, left parasternal heave indicates right ventricular hypertrophy. Whereas the apex beat, we are mainly concerned with the LV function. The features have been already discussed. Look for thrill. A displaced apex beat means LV enlargement. There are two types of LV hypertrophy. One is the concentric hypertrophy and another is the eccentric hypertrophy. In concentric hypertrophy, the ventricle thickens at the expense of the cavity. So there will not be much enlargement unless the patient goes into heart failure. In volume overload conditions like mitral regurgitation, aortic regurgitation, dilated cardiomyopathy, apex is shifted. So this is a volume overload situation. Usually you get a, but in heart failure due to anemia or due to beriberi, etc., you may get a enlarged heart. So if it's a valvular heart disease, it's a volume overload condition. There is a point I want to stress. So once you are inspected and palpate for thrill and parasternal heave, these are the two important things. Now you go for auscultation. Identify the first heart sound, second heart sound, and we are mainly here concerned with the gallop, especially the third heart sound. So what is a gallop? S3 gallop. The presence of an additional heart sound in the presence of tachycardia gives the appearance of the cadence of a horse. That is called the gallop. So when S3 and S4, it is called the summation gallop. Summation gallop. Sometimes called quadruple. or if S3 alone, you call it an S3 gather. You will be looking at for murmurs, especially MR murmur, TR murmur. In heart failure, you will be looking for additional murmurs as the etiology, for example, mitocinosis. Infective endocarditis is the development of an MR. Somebody with the acute coronary syndrome, again look for MR. We can get an acute VSD. For all valvular lesions should be looked for, examined carefully. And tricuspid regurgitation should be specifically looked for, and you know the features of TR. 3 cardinal findings of TR. One is JVP, you get a B wave, prominent B wave, or CV wave. In the palpation abdomen, you get a pulsatile liver, and auscultation, you get a murmur parasternal or tricuspid region murmur with increase on inspiration. So this is important. Once you examine the cardiac examination, auscultated the carotids and all relevant regions, you will be looking for basal crepitations. Because we have already mentioned that when the heart fails, the lung gets congested because of the back pressure, Starling slow, interstitial edema and alveolar edema. So basal crepitation, that is a point to be remembered. Basal creps. And sometimes not only crepitation, sometimes because of the peribronchial edema, you may get a significant bronchi. That is why the statement, all the wheezes are not asthma and all asthmatics may not wheeze. So left heart failure can also imitate an acute exacerbation of asthma or COPD. That should be looked for. Pleural effusion can occur especially on the right side, and the breath sounds may be decreased due to these reasons. Then do an abdominal examination. In the abdominal examination, you are mainly concerned with the two things. One is whether liver is palpable, second is the spleen is palpable. So liver is usually soft liver, tender liver, and in the liver, two things you will be specifically looking whether there is a pulsatile liver. Pulsatile liver is seen in tricuspid regurgitation. Keep one hand anteriorly and one hand posteriorly and see whether the liver, if each heartbeat the liver is pulsating. Palpation of the spleen. Palpation of the spleen is important when you are suspecting infective endocarditis, especially subacute infective endocarditis. So as per Hutchison, splenomegaly suggests infective endocarditis. So in the abdominal examination, rarely you may get fluid. Ascites is not a very common thing in heart failure, but the patient can develop a cardiac cirrhosis. Chronic venous condition can lead to cardiac cirrhosis, and we may get a ascites also. So abdominal examination, we are mainly you are interested in the palpation of the liver. We have said that what are the things to be looked for, and palpation of spleen. Now we go to the severity assessment. One, symptoms. Last time we have mentioned that the symptoms, exercise tolerance, these are all significant for assessing the severity. Second is looking at the JVP, which indicates a right heart failure. Looking for edema, looking for LVS3, crepitations, hepatomegaly. So remember this statement, severity is judged clinically. Not by the investigations and echocardiogram, it is the clinical diagnosis. Severity should be assessed. Hope that point to be stressed. So the skill assessment during a cardiac examination, checking the vitals, examine the JVP properly, systematic examination the proper way, the apex beat, and other things which I have discussed, and correlate the findings. So take home message, look, feel and listen. The diagnosis will be clear. So this is the take home message, look, feel and listen. Stay tuned for further videos. Thank you.